Hello and welcome to the FAPESP COVID-19 Research Webinar Series, Contact Tracing and Lockdown Easing Plan, Effectiveness and Limitations. So this is the third webinar of the COVID series organized by FAPESP, the São Paulo Research Foundation, and this webinar is supported by the Global Research Council. For starters, I'm pleased to welcome the FAPESP Scientific Director, Professor Luis Eugênio de Mello, to give the welcome address and open the session. Luis, you have the screen.
Thank you, Leonie. It's a great pleasure to open this third of our webinar series on COVID. It's an honor to welcome a distinguished panel of experts. Brazil, as many of us know, we're crazy about sports, mainly about soccer. And that's a national passion. One of the most interesting sayings nowadays is that a number of specialists don't see, it's very anxious to see when this pandemic will be over, because rather than having 200 million specialists in soccer, we're currently having 200 million specialists in COVID. And of course, we don't have 200 specialists in COVID. It's definitely quite important to understand and to see what's the different views of specialists from different corners of the world. And most of all, it's quite relevant for us to understand how behavior may shape the outcome of this pandemic, given that vaccine, even though it's a current strong effort around the globe, it's definitely many months away from us. And what is currently available is behavioral measures, and contact tracing is definitely one of them. With that, I hand back the word to Leonie and wish us all a great event.
Thank you, Luis. So before we start, now that everybody's settled in, I'd like to share some details about how this webinar will be run. So first, I'd like to remind everybody to mute your microphone so it doesn't interfere with the broadcast. And as you proceed through the talks, there'll be questions. Please feel free. We actually really would like you to participate by sending your questions via email to live@fapesp.br. So these questions will be forwarded to me, and at the end of all talks, we'll have a question and answer sessions in which the speakers will answer your questions. Also, at the end of the webinar, we will have a request. We'll request you to unblock your cameras so they can have a moment of human warmth and take a picture of everybody, including the audience. And in case you missed some of the talks for other reasons, this webinar is being recorded and be available later in your YouTube channel. So thank you for coming and enjoy the talks. Our first speaker will be Dr. Ikong. He's the Deputy Director at the FCT Health and Human Services Secretariat at Abuja in Nigeria. He has over 10 years experience in e-health governance in the health sector. He led the development of the first e-health policy and strategy document in Nigeria. And during the COVID pandemic, Dr. Ikong is striving to implement privacy-sensitive information communication technology, that is ICT-enabled strategies for surveillance and contact tracing. So during this process, Dr. Ikong has identified challenges that suggest that risk communication and community engagement need to be included the planning, and is deploying a mobile web platform for risk stratification and identification of disease clusters to inform public health action. So he'll tell us a little bit about challenges related to privacy of the population that have been jeopardizing the implementation of a contact tracing app to map COVID-19 in Nigeria. So Dr. Ikong, thank you for joining us and sharing your time and idea with us. The screen is yours.
Thank you very much, Anna. It's a privilege to be here today on this platform to discuss on the little experience that I have had in the course of responding to COVID-19. I'm happy to be here, particularly because Brazil is a country that I love so much. And I'm happy that I'm going to contribute the little knowledge that I have in improving the outcome of the response in Brazil. So this is my outline. This is the outline of my, sorry, I got the wrong slide. All right, so I'm just going to talk about the finding a suitable case for contact tracing and surveillance in regards to patient data privacy. So, you know, I'm sure this is what a lot of us here already know. This COVID-19 pandemic, which came with lightning speed from December in China, and it spread to where we are now. You know, it's changed everything that we never expected. So it actually appeared in Lagos on 27th of February, and 12 days before it was declared a pandemic by the World Health Organization, and then disappeared suddenly and reappeared in the Federal Capital Territory where I work 9 days later on March 20th. And presently we have quite a number of cases and deaths, which I don't like counting. So basically, there is no drug for this or vaccine and other pharmaceutical measures. So this makes non-pharmaceutical measures the cornerstone of the response. And then it must be in a way that is as speedily as the virus itself. Therefore, it means that any strategy will adopted has to be very quick to match or even outsmart the velocity of the spread of the virus. So this created the need to develop and adopt digitally enabled strategies to facilitate a response in a seamless and timeless manner. So we figured out, I and my co-authors in the paper we published, we figured that an effective surveillance and contact tracing can help to halt the rapid spread of the pandemic. And then also we looked at what the country strategies are as regarding the use of ICT to improve the response. So that took us to analyze quite a number of ICT-enabled response by several countries across the globe. And we got some major findings and recommendations, which included that the mobile positioning data use for contact tracing and surveillance is quite promising and will definitely help to timely contain the outbreak, especially when it's implemented at the very early stage where the disease transmission is not that complicated. Yes, it might be very promising, but it also has a lot of challenges around specifically around patient data privacy concerns from abuse or breach in citizen data privacy to other technological challenges that is capable, you know, of disrupting the implementation of such digital technologies. So we came to the conclusion that every country must find a suitable use case, you know, for its own response without necessarily infringing on citizens' privacy. For instance, using a very simple technology such as USSD or IVR can prove very useful. And therefore, what it should take the patient data privacy concerns into cognizance. So this is just a slide showing some of the responses, by so many countries across the globe using technology. So the common findings with all these digital enabled strategies is that some of them were found to be voluntary or in some cases mandatory. That is, government mandated citizens to utilize these mobile applications. In other cases, they dealt with aggregate data that were anonymized, and in some cases, they actually dealt with patient level data. So the high rate of community infection with expansive and complicated contact tracing would be a lot easier at the beginning of a pandemic, where you have less complicated contacts to trace. Based on these new learnings, we thought it is important to look at the practical issues that for any country that wants to deploy mobile positioning data or any other technological strategies in their response to COVID-19, to look at issues around the availability of policy guideline. In most cases, it's absent for policy guideline for mobile positioning data and use in contact tracing, with clearly defined rules for all the stakeholders. And then for instance, with the current launch of the COVID-19 notification services by Apple and Google, there is need for such a country to have a suitable public health authority application for contact tracing. And then there's need to consider the high cost of deploying such technology and also sustaining them throughout the response. And most importantly is the issue of the lack of public trust in government, which is resulting in resistance to disclosure of location data by citizens. Also, some of the findings were that of the high level of myths and misconceptions about COVID-19 as either being a conspiracy or a disease of the rich. I mean, we have quite a lot of misconceptions, with people refusing to believe that it actually exists. And that is bringing a lot of challenges around compliance with any technology for contact tracing that is being deployed. And then you consider the issue of the digital divide between urban and rural areas in terms of the use of smartphone devices and the last mile connectivity issues, particularly in rural communities, who in our own case make a significant number of the target population. And also one of the challenges we noticed was the lack of autonomy. For instance, at a subnational level where we find ourselves, we still need to, find some way to get federally controlled mobile network operators, to share location data with us. So all these challenges led for us to reappraise the situation and then look at new approaches that we can utilize to bring about optimal, gains. So this led to suggesting a more investment in risk communication and community engagements, so as to get the trust of the citizen in participating and sharing their location data to improve, the situation with contact tracing. So we'll look at community monitoring and risk stratification platform as a low-hanging, cost-effective, and community-friendly approach, which is expected to increase public trust in government. So this led us to deploy this community monitoring and risk stratification platform using mobile or USSD or desk application that allows individuals and populations at risk to continuously monitor and report themselves either once or twice weekly through a self-assessment of COVID-19 symptoms. This information, this also allows information and advice to be given to them regarding particularly comply adherence to preventive measures and behavioral changes to both the general and the target communities. And then it also allows symptoms to be monitored for those who are on quarantine, and then in a very speedily manner to screen a large number of population at the same time, classifying their risk status based on the case definition algorithm that we are using. So, and then the data that is gotten can also be visualized on a map to see the hotspots areas where you have a lot of symptoms in the communities. And then with the challenges of the unavailability, inadequate testing, you can easily mobilize testing to these hotspots, to test the community members. So we have a USSD code that currently we've publicized. And once you individuals save it in their phones, they can dial the code once a week or twice, and then they get advice on COVID-19. So at this point, I would just like to share my screen on the risk platform that we have. So when citizens use that code, they take a self-assessment of themselves based on several symptoms which they notice at that particular time. And that comes to this dashboard, which is showing responses, with biodata and unique code, without names notably, to protect people's privacy. And then it's allowing multiple use by households or communities who own just a single device by generating the client code that can be generated according to the number of users. And so the area council where these individuals are located can be seen, the settlements or the areas can be seen, and then their risk status is classified using the available algorithm. And then also it shows you the forms that they completed, the symptoms they had, for instance, if they have been tested, or there's fever, cough, and all that. And then also this can be visualized on a map. This whole location of people who took the responses can be visualized on a map to show the hotspots. So if you take a look at this, okay, so you can easily see where the cases are located. So you can see the hotspots, like here, for instance, you see here, this is Dabe, and then you can easily mobilize to test these areas. And eventually, when these individuals are now tested, you can see whether their test is positive or negative. And then you can also go back to the map and visualize, the transmission. So basically, this is a very, very cost-effective strategy that we have utilized. And we feel for resource limited settings like us, we can easily just use this to improve the current response. So the recommendation in adopting an ICT for COVID-19 response, all countries must consider a suitable use case, which should be informed by clear policy guidelines around how data will be shared between health authorities and the mobile network operators. And there must also be good data governance policies that is privacy sensitive, so as to improve the social inclusiveness in the entire response. And then the issues of costs and effectiveness, cost effectiveness and sustainability must also be considered. For realization of optimal benefits, such a solution should not be used as a standalone, but rather work in synergy with other strategies. It should be deployed early enough in the pandemic response, and or to regions with lower infection rate. In that case, it will be more easy because the number of cases are not so high, and the contact tracing is not as complicated. So, and then it should be tested and optimized before deployment to scale, and should not be prioritized over simple inclusive strategies capable of increasing citizens' participation and ownership of the response. Thank you so much.
So I'll ask everybody to unmute the microphones and give them a real loud round of applause and appreciation for sharing his ideas with us. So the question, like I said in the beginning, the questions and answers session will be at the end of all the talks. And our next speaker will be Professor Leonie Lemos. Professor Leonie was a former Secretary of Planning, Budget and Management of Rio Grande do Sul and coordinator of Data Committee for COVID-19. As Planning Secretary of the State of Rio Grande do Sul, which is in the south of Brazil, during the initial phase of the COVID pandemic, Dr. Lemos successfully implemented a controlled social distancing policy in its state and achieved the lowest infection mortality rate in Brazil. Their strategic planning relied on multiple scientific analysis, including mathematical projections and sample testing. So here she will share with us the experience of using scientific data to successfully develop an action plan for social distancing policy implemented in the southern state of Rio Grande do Sul. Thank you, Professor Leonie, for joining us, and please have the screen.
Thank you for the invitation, and I'm super happy to be here and to share a little bit of our experience here in trying to live with this pandemic. I'm going to start sharing here, so I hope everybody's seeing. Okay, are you all to get it?
Yes.
Okay, so as our moderator said, we've been working since at least March in trying to establish a different kind of strategy in dealing with the pandemic. What we did is trying to avoid the worst, not denying the pandemic as we have seen in different parts of the world, and especially in Brazil. So basically what we try to do is, it's not about randomly lifting restrictions or reopening or going back to normality, but trying to establish a strategy where we can live with this virus for a long time. So the first thing we did was we start early and focus is on life. So safety is really important in all this model that we have established. Second important point is that we have established a data-driven approach. The governor is super analytical and he likes to see the small numbers. So we have improved the system. For 2 months, we have improved, trying to get better numbers and systems in the state. What we see around Brazil is that you don't know what's going on in the hospitals. You don't know what's going on in the private and public hospitals we have. So it was very important to establish systems where the hospitals are obliged to fill in forms and say how many patients they have in the ICTs, how many are COVID confirmed, how many are suspects, and this kind of information. I'm going to show you some of the information that we've been using to establish then these alert system. We use flags, risk flags, to say to communicate with society, but also to establish different protocols and adjust economic activity to these risk levels. So we created this alert system, we adjust economic activity according to the risk level, and we use protocols where it is and where it is not critical. Everybody has protocols to follow, even if you're in an area where there is no case, but you have to follow protocols. And this all was done with a lot of collaboration. The data committee that I'm now coordinating, we have today about 150 specialists. About half of them are from the government. The others are from the universities, centers of research, and even the syndicates of workers and syndicates of the economic activities in different industries. They participate in this model. Of course, they complain a lot when we say, well, we cannot open because it's a risk area. Of course, that's part of the game. But they are all in the same table and everything is transparent. And we have created public dashboards and public all the data that we collect and how you calculate the flags. Everything is available on site, and the open knowledge transparency, COVID transparency, has put the state now in first in the national ranking of transparency. So what we did in our model in the first place was to regionalize. We have in the Rio Grande do Sul 30 health regions and 7 health macro regions, but we have established a different one in which each region has a hospital with ICT beds. So this is how we have. I'm going to send you, Ana Paula, the presentation so that everybody can have it afterwards. So then we set up to establish the flags, in which we measure 2 big groups: the spread of COVID-19 and the service capacity of the healthcare system. And each of the groups, they have 50% of the weight in the flag definition, and we track 11 different indicators. And so this is just a general view. So we'll look at the rate of the advance in the coronavirus. So we measure the variation of hospitalizations, number of ICT by SARS, by clinical beds, ICT beds, ratio between active and COVID cases, incidence of cases, overpopulation, projection of deaths. We used to use the death number, but we realized that they were very modest, and we adjusted to projecting death in 2 weeks. And the service capacity, the state capacity in providing health care for the population that need it. So it's very important to measure and also the changes over time. So changing one week over the other, that's very important, because what we have seen up to now is that the deaths, they are not because the lack of ICT care. It's not because of lack of assistance, and that's where we've been working hard, is trying to maintain cases under a certain limit so that we don't have the failure of the health system. So we apply, each indicator has a flag and then a general score for each of the regions. I'm going to show you the maps afterwards. Also, what we did was the sector segmentation, talking about now the economic activity. We looked at, we organized it in 12 groups. In the beginning, 50 industries, but now we are over 100. And we create the sectorial index in which we'll look at safety of that sector regarding contagion and economic impact of that in the GDP, at the state level GDP. So we used information from different parts of the world, and we create this matrix where we see the impact on safety and on GDP, and then you see 12 sectors and the more than 100 activities. And it's 2/3 of this weight is for safety, 1/3 is the weight of this economic sector in the economy. And so we design protocols that are different according to this matrix here. And looking at protocols, we look at what we did benchmarking, international and national benchmarking. We also submitted to society in 2 different rounds. We had expert teams of strategic planning and health secretaries, but also outside members, independent experts. And so we have also disaggregation of the sectors to look at specific areas or services, especially services or industries that need a special look, like the long-term care institutions for the elderly. So they have specific, very specific protocols. So society engagement was really important. We have received emails, and this is the cloud, the word cloud that is in Portuguese. So you don't, those who don't speak Portuguese won't see it, but it's talk about masks, EPIs, equipment. I don't know how to say it, EPIs in English, equipments, EPIs in English, education, trade, etc. So this is ABI that we have built on the different visions and who have contributed to the design of the protocols that are now in place, and the level of acceptability of the different protocols for from these different sectors. So this is an example of how the retail have contributed to the different protocols that we are adopting right now. So we have specific ones, general ones, those who are mandatory. So everybody has to use masks. Even if you're in a low risk area, you have to use masks, public and workers in industries. The social distancing, the meter distancing, sanitation, visible information, group risks at work, so protect, send them home. We have protocols for those who are positive or are suspects who have some how to say that? I'm sorry. Who have the convalescent. It's terrible when you don't have the word. Well, but if you suspect is you have a cough, you have fever, so you have different protocols if you're working and start having some symptoms. That's it. So also temperature monitoring, testing. Some industries have adopted testing. This is not mandatory, but this is recommended, especially on, for instance, meat packing that has some surge of the coronavirus. This is how it looks in the side. So you have, if you were retail in the yellow flag, so you have to follow different kinds of protocols. If it's orange, it changes more, it's stricter rules, even stricter to red, and then flag where you close basically everything. Or on essential items like food, you have a strong restriction on number of workers that are working on person, but you have delivery, drive-through, and this kind of thing on the essential items or essential industries. Everything is in this website with distanciamento controlado, rs.gov.br, and then it explains, and you have educative videos too. We have the flag of the week, and then you can put your municipality, your city, and then it comes out which flag it is, and then the protocols you can download and everything's basically there. So we have this flag right now. I'm going to show you the 8 weeks. We've been doing that for 8 weeks now. And this is the last one in which you see that an area, it's basically, the state of Rio Grande do Sul is about 12 million people, and today about 5 million are living on the red flags. So this is really important, but I'm going to show you this. So in the first week, we have some that were high risk, and now they are out of risk. And this is a difference here of, this is the one that came out of the model, but now we have a time for debating with the mayors, with other experts, and in which we assess, because many of those, we only use 11 indicators, but we have other ones that we discuss outside, and then we realize that some are not really high risk, but medium risk. So this is the final one. This is the preliminary one. And here we see the last 4 weeks, what has happened in the 20 different regions, in which we see that some that are really concerning and going high. And in these areas now that are over the red flag, we have the red line here to mark the red flag. Those who are in the red flag, they are they have closed retails, and now we have basically starting a very strong action so as to reduce this curve. And like others have done, if you look at the last one here, Lajeado, the last one was in higher risk and now is going down, and we have 6 or 7 regions in which you have this happening. So we have different, it's like comparing different regions in which the pandemic or the COVID has different, or either in different stages or are more controlled. We also compare what's been happening in last weeks, and this is basically what we are doing there. So besides this model that we have designed and it's now in place, there are 2 other very important actions that the data committee is providing to the risk cabinet that basically almost every day we have meetings. One is a random research on prevalence that we are now in the 5th phase. Today we are going to make it public in the afternoon, and up for the last 2.5 months, and it's under 0.5% the prevalence of coronavirus in Rio Grande do Sul. The other very important contribution of the data committee is on projections. We do it daily, but we present it every 2 weeks to the risk cabinet on mathematical projections on ICT occupation and clinical occupation, and also on number of deaths. And this is also a great contribution that universities have been giving us. So I'm open to questions. And again, very nice, and thank you for making it possible to present what we're doing in the state.
Thank you, Professor Leonie, for sharing with us such an amazing structure that you've established. So any questions should be directed by email to live@fapesp.br, FAPESP.br, and they will be directed to the speakers at the end of all the talks, and we will have a question and answer session. So I ask everybody to now unmute their mics to just give a live round of applause to Professor Leonie for her great talk. And now we'll proceed to the next speaker. So the next speaker is Professor Elden Nakaya. Elden is assistant professor at the Faculty of Pharmaceutical Sciences. Thank you, Elden, for joining us. It's also known as Faculdade de Ciências Farmacêuticas at the Universidade de São Paulo in Brazil. Professor Nakaya uses system biology to predict and understand immune responses to different vaccines. So currently, he's also part of a collaborative effort to develop a low-cost diagnostic platform for COVID. As the principal investigator of the FAPESP-funded Center for Research in Inflammatory Diseases, he developed a privacy-sensitive cell phone platform to map hotspots of transmission of different diseases. So he's now currently working on a cell phone app to trace COVID-19 hotspots, which was originally developed to map malaria dengue hotspots. So he'll tell us today how to deal with privacy concerns in order to apply the platform successfully and on a large scale. He's also going to talk about other tools and analytical methods applied to forecast the COVID epidemics. Thank you, Elden. You have the screen.
Thank you so much, Leonie, and thanks, FAPESP, for inviting me to give this talk. Let me share my screen. Okay, I hope everyone can see it. So today I will tell you about what we have been doing for contact tracing and how this can be used to guide lockdown strategies. Well, we started working with contact tracing back in 2015, way before the pandemics. And in 2017, we got funded by Bill Melinda Gates Foundation to mapping hotspots for mosquito-human malaria transmissions. So using this grant, we developed this software called Cephas, which is the same thing as the GPS, but instead of global, is sickness positioning systems. So that was developed by Lucas and then Jivan. So the idea was very simple. Instead of like asking people, where have you been 10 days before you get malaria or 14 days before you get malaria, why not using the GPS history data of the cell phone of these patients? So we create this platform that allows the patients to donate their GPS history data in an anonymous way and with their consent. And after we receive the data, we can analyze, looking back and cross-reference with many patients to see where are the hotspots of transmissions. So using over 200 patients, we saw some potential hotspots of transmissions close to Manaus that were never described as an endemic area for malaria. So our collaborators there in Manaus, they sent public health agents to some of these places, collect the water from this place and found larvae of mosquitoes that transmit the malaria. That kind of validates the usefulness of this kind of strategy to identify new hotspots of transmissions. And we also apply Cephas to another disease, which is tuberculosis. And that was a collaboration with the Reports Consortium. And of course, tuberculosis is a different question that we have, which is the contact investigation. So for example, when someone arrives to a hospital with active tuberculosis, you ask the patients who are their contacts. So you want to know actually how long do you spend with your close contacts, what is the distance. So, but do you all agree that it's very hard to remember if you spend 2 hours with your mother per week or 3 hours with your girlfriend per week, right? So you can use the history data of the cell phone from the patient and the contacts to find out if they were in the same place at the same time and for how long. And that's showing here, for example, a pair of contacts that they stay together several times and for a long time in these specific areas. And then you can measure and test if the person's get infected with the Mycobacterium tuberculosis. We also apply Cephas to chikungunya, but chikungunya we use for a different purpose. So chikungunya is a disease that can cause arthritis. So we were trying to see if the mobility pattern of a patient with chikungunya will change when they have symptoms. So if you look at one patient that walks and cycles to go to work every day, you see that the time periods pre-exposure and the exposure, this is the activity that they have. When they start having the symptoms, the activity drops a lot, and this is after he's recovered. So this is important because to know precisely the onset of disease is a very important information. And sometimes you don't remember if you have a fever or if you have the symptoms 7 days or 8 days before. And of course, when COVID-19 pandemic hit us, we were already prepared with Cephas to study that. So what we needed was the patients. And the patients were provided by our collaborator, Leonie, from the medical schools, and a lot of other people and students. And Julio Crolla also provides patients from other states. So with COVID, when SARS-CoV-2 infects you, it takes around 5 days for you to start developing the symptoms. And at some point, you decide to get tested. And then you are confirmed or not. The problem with COVID-19 is that, as you all know, is that the transmission periods actually happen even before you start the symptoms. So, of course, you all know also that asymptomatic people may transmit the virus. So the question is, can we use Cephas to see where a COVID-19 patient's been to during the transmission periods, so we can act upon this information? So, for example, this is one patient, and the red is where the person was when the person was transmitting. And these are subway stations. You see that probably the person went to work during the transmission phase by subway and infects a lot of people in the way. And if you change the subject, this is the pattern where the person went. And this is another COVID-19 patient. So you see, that's kind of scary, because you see that when you get tested and get positive and you decide to stay home, it's maybe too late, because you already walk all over the city, and probably new cases are going to happen here. So when I was talking to a colleague about Cephas, he introduced me to Andre, which is the CEO of InLocal Startup. So this startup holds 60 million devices in their database. They record 1.8 billion visits per month, and they receive over 16 terabytes of data every single day of locations of cell phones. And then we quickly established a collaboration. So this paper was submitted 1 month after the first Brazilian COVID-19 patient was identified. So here you can see in the rows that each neighborhood of São Paulo city, red means that the people are moving around, blue means that the people were not moving around. So these are normalized data. So as you can see, during Carnival, actually, when the first Brazilian COVID-19 patient was identified, people did not move much or left the cell phone at home. This is when there is a huge flooding in São Paulo that stopped the whole city. And this is when the social distance policy started. You can clearly see that the whole city stopped moving around. And instead of neighborhoods, you can also look at the type of places that were more or less visits. So these are the visits of universe from the top 10 biggest Brazilian capitals. So as you can see here, so after March 14, most of the people stopped going to universities. And that's the same pattern for schools, gyms, museums, bookshops. So you can clearly see, using the cell phone data provided by InLocal, that people stopped going to these places. However, if you look at visits to gas stations, you see that after March 14, there is a drop, but then it goes back to normal. And if you look at car shops and car washes, have a very similar pattern. So that means that people are not going to university, but they are driving somewhere. So they're driving to where? Well, some of the places that they are driving are to pharmacies and supermarkets. As you can see that after March 14, they stopped going there, but then they go there again. They start going there again. But of course, pharmacies and supermarkets are essential places. They have to go there. But what about bakeries and hair salons? So you see that people stopped going there on March 14, but the activity went back to normal, although the government had said that you should avoid this kind of places. And if you look at some specific capitals, so this is Salvador, and this is the activity, the number of visits in hair salons in Salvador compared to the time before the pandemic. So you see that they are going even more than before. So in order to understand how this mobility data can be used to study the spreads of the disease, we collaborate with a lot of researchers, especially people from Julio Croda's team. And we start trying to associate the mobility data, the isolation score provided by InLocal with the RT values. So I'm not going to talk about that because I saw that the first FAPESP webinar was a wonderful webinar, was only about that, and that you can go to there to find out. So one thing that we notice is that some cities, an isolation score above or equal 50% could indeed prevent the spread of the disease. So what about visualization? You are all familiar with John Hopkins coronavirus map, right? This beautiful dashboard that you can see all the cases and everything red, very scary. The thing is that if you want to make your own dashboard, if you want to display your own data that you got from a different source, you have to pay a lot of money to use this software, or you have to know a lot of, you have to have a lot of computational skills to make something like that. So we create this tool called Outbreak, which is a user-friendly online tool that can be used for disease surveillance. So this is the website that you can go there. So what you can do is you just type a title that you want, a description. In that case, I put the 10 million cases that of COVID-19 that WHO provided. And here is the inputs file that you need. You need a file that has latitude, longitude, case, the color that you want the dots, the size, and the dates of the cases. So that's the only thing that you have to provide. Then you drag the file here. It opens a map like that with a calendar. You choose when you want to start the animation. And when you hit play, you start seeing how 10 million cases happen over time. You see that, of course, as you all know, started in China, went to Europe, and then after spread to the whole world. The thing is that the data that we have only gave us the one pair of latitudes and longitudes for Brazil, Russia. So you cannot do like a disease surveillance at a city level or at a neighborhood level. So we made a collaboration with Rafael Pereira and people from IPEA and CADE that provides us with the data of COVID-19 cases in Sao Paulo and also severe acute respiratory infection cases in Sao Paulo. And most of these cases of severe acute respiratory infection are actually COVID-19, but you don't know because they were not tested. So this is the University of Sao Paulo. FAPESP is around here. So just to see that you can zoom in whatever you want. And these are the blue dots, the severe acute respiratory infection. The red dots are the COVID-19 confirmed cases. And then when you start the animation, you can really see what's going on in the neighborhoods close to you. You can actually see that the disease spread to the small cities in the countrysides. And of course, if you want to see how many cases are in your neighborhoods and also the time that this happened, you can show in the calendar and zoom in and start doing some action about it. So I leave you with some open questions about contact tracing and lockdown easing plan. So for example, contact tracing, there is a lot of apps around. There are plenty of data that people can use to create models and to visualize. The question is, which ones are the best ones? Which ones should you choose to do, for example, to make a nice and robust epidemiological models? And also, if you're going to use these data to do epidemiological models, what is the minimum required uptake for you to create good models? For example, how many app users you need to have a reliable information to run your models? And when we develop the models, which parameters you're going to use, which variables, which assumptions you're going to use. And with the results of this model, you can use to guide the authorities and the public to do either lockdown or easy plan. But the question is how you're going to communicate or alert these people based on complex mathematical equations. And the public can, or the authorities can choose to lock down, how you're going to enforce it, how you're going to protect the people financially, health-wise, and also you can decide to lose the restriction on the lockdown. But then what is the best strategy? Which place you're going to open, how you're going to allow? I think I just saw that the previous two talks were nicely talking about that. And also the plenty of apps and data can be directly used to the authorities and public, but the question is how to convince people to use it. You know, like, are they just high-tech distractions, or they just pretty apps that do not really help this case, or they are gonna help? And you're gonna see the last seminar about that. So I think that maybe contact tracing is already too late because people are transmitting even before you start the symptoms. So maybe we can use this technology to do like some contact prevention. So we did not develop this, but I wish someone start investing on this, such as like a ways for places. So where you can before you go to a mail office, you can check if the place how full the place is, and also like what is the best time to go there, because in that sense I can decide if I'm gonna leave my house to go to this place before or should I wait a little bit longer. With that, I have a lot of people to acknowledge and thanks for all these projects and the people from my team. And of course, thanks everyone, including a lot for FAPESP.
Thank you, Elder. So we ask everybody to unblock their mics again and give Elder appreciation applause, please.
Thank you.
So just to remind everybody, if you have any questions, please email them to LIVE, they'll be live, at FAPESP.br. And Elder, it's interesting that you mentioned at the end complex mathematical equations, because this is exactly what we're going to have up next. So I'm happy to welcome Professor Jorge Velasco Hernandez, who's a researcher at the Instituto de Matemáticas of the Universidad Nacional Autónoma de México. He's a fellow of the Society for Industrial and Applied Mathematics, International Fellow of the Santa Fe Institute, member of the Academia Mexicana de Ciencias, and former president of the Sociedad Matemática Mexicana. So Professor Velasco studies the population level impact of three key factors: the implementation of behavior change, control measures, the time horizon necessary to reduce the effective contact rate, and the proportion of people under sanitary emergency measures in combating COVID-19. So he'll talk about modeling behavioral change and COVID-19 containment in Mexico, a trade-off between lockdown and compliance. Dr. Velasco, thank you again for joining us. Please have the screen.
Thank you very much for the invitation. It's a pleasure to talk to you and to present our work. Let me see. Do you see the screen?
Yes.
Okay.
Yes.
Then I'll
Yes, it's fine.
start. This is a work that we are doing here in Mexico from the early March, mid-March. And this work is being is given to the National University of Mexico, which is a very large university also, like the Sao Paulo, and has many campi around the country, and has a problem with obviously planning the lifting of mitigation measures and other issues that relate to the evolution of the disease. And we've been advising also the government of the Mexico City on the same topics. So the approach that we've taken is not to generate too complex model to predict difficult things that that are necessary, but are really, really difficult to estimate using mathematical models. And we chose to go more in the strategic scenario in order to provide projections in order to give clues to the people in decision-making about the epidemic. And let me just show you the names of my collaborators. The two first are my students, and the other two are collaborators from the National University and the Sonora State University. Let me start just for a bit of context. Mexico confirmed its first case in late February. Then in March 18, the Secretary of Education closed essentially the schools, and on March 23rd, there was a national program of closure for different institutions in Mexico, and then on June, in March 30th, a general social distancing program took place, and all non-essential activities were restricted, and only those deemed essential, like hospitals and these kind of institutions, were left to function. And on June 1st, the government decided that was time to lift the restrictions. And this is where we are now, and we are in a big problem as many other parts of the world. The data that we have is the data that is provided by Mexico City government and by the Dirección General de Epidemiología, the Directorate of Epidemiology in Mexico, federal government, which have provided many different aspects of the data on COVID, not sufficient in many cases, but that's what we have, and that's what we work with. Essentially, I'm going to show you the data on incidents or related to symptoms onset. There are many other records of incidents, but we are going to choose that because that's a better indication of the active infections in any time in the epidemics that we are having. And that's the general shape. This is the data of Mexico City about a week ago, and this is the typical form that we have now. It's important to point out that the model that I'm going to show you is a strategic model, and one of the first things that was required from us was to provide, as is common in these days, the incidence at the maximum date of incidence, for example, and the dates in which this peak will occur. To predict the level of incidence is very difficult. It's a lot of uncertainty. The dates are a little bit easier, and we projected that to occur by the end of June. That happened to be true, but the problem is that, as you can see in the graph that I'm showing you here, the Mexico City entered not in a classical bell-shaped curve, but essentially it has remained there since approximately May 20th in this kind of plateau. That is, this week, as we speak, is still going with some signs of decrease, but many of us think that this is only a temporary decrease that is going to go and rebound again in the following days. But this is the scenario that we have here. And the point is that using these kind of very simple models that approach the epidemic from the contact rates and transmission processes, we put special attention in the mobility events that are atypical, that some of them were shown in the previous talk. And in Mexico, we have particularly in the early days of May, two very important holiday family dates. One is Children's Day that took place on April 30th, and the other is Mother's Day that took place on May 10. And these are family-related holidays. That means that transmission is heightened because transmission is occurring now in the families, which is really dangerous, and it had an impact on the epidemic that we are. First of all, we approach the problem of determining how efficient were the measures that government implemented for lockdown, for flattening the curve. And for that, we use a very simple model, the Richards model that I'm showing you there. This is a simply logistic approximation in which you have essentially the dynamics described by the growth rate of the epidemic, the total number of cases that you expect to have, and a parameter that gives you some freedom on determining the asymmetry of the growth curve, of the epidemic curve. So with this very simple model, observe that this model doesn't take into account the transmission of the disease. It's not a mechanistic model, but it gives you a fair approximation of very basic data. We first estimated the epidemics before any measures were taken from February 22nd to March 22nd. And then after the measures were implemented by the government, we took from March 23rd to June 1st, where the mitigation measures were ended and the lifting of restrictions occurred. As you can see, the important parameters is really are. This is the growth rate of the epidemic before the lockdown measures, and this is the growth rate of the epidemic after the lockdown measures. And you can see that in the median, you have a fairly large reduction, like 90%. However, as we know, this epidemic, this new virus and the nature of the exponential growth of the initial phase of the epidemic makes a lot of uncertainty in the data. So if we look at a very optimistic scenario, well, we have a median of 1 before the lockdown, 0.12 after that, 90% reduction. But if we look at the lower end of this is only 0.4, and then the upper end of here, this one is 0.16, and it's only amount about 40% reduction. So the main message that we can give from this is that the lockdown measures worked, but to have a good estimate of how well they worked is, I don't think, feasible. In any measure, you can consider better estimates using mobility data or other proxies for lowering the contact rate, but it's really, really very uncertain. But the fact is that it was reduced, that's what we think. And then the next problem is once you flatten the curve, when is the maximum peak of incidence? And so if we know that peak, we can plan. And this is the curve that we have at the end. The government estimates, the federal government estimates, underestimated the peak. They estimated to be around May 6th. It actually occurred May 20th. And because of this, or maybe this was a factor, they planned the reopening of the lifting of restrictions towards the end of May. And that coincided, as you can see, with the height of the epidemic, the area of maximum incidence. But still, this is a plateau. Why this occurred? What I'm showing you here is just the typical bell-shaped adjustment of the Richards model. And we know that that model doesn't give you good estimates of this plateau. It assumes that this just noise or is some kind of perturbation of the data. And you can see the estimation of the logistic growth is the bell-shaped curve. And we know that this is not true. This is a misleading kind of approximating epidemic curves. So what I'm going to show you now is some data on the effective reproduction number of Mexico City, where you can see all these events of mobility reflected on the reproduction number. This is Mexico City. This is the incidence that we have up to the end of May. And this is the trend that the effective reproduction number had. As you can see, to have here an indication, after the first, the implementation of measures, the reproduction number more or less was kept flat. Then it was a substantial decrease. But then, as you can see, it came 30th April, Children's Day, and then it came Mother's Day. And as you can see, the reproductive number had an increase. And instead of just happening on around the 30th and around the 10th of May, it lasted from essentially April 30th to May 10th. Apparently, the Mexican people in Mexico City went to see their mothers, but the whole week. And this has a problem because it can be explained because Children's Day occurred in a Thursday, whereas Mother's Day happened on a weekend. And these are very close dates, and children were not at school. So it was a noticeable increase of people going to buying things to the supermarket, presents, piñatas, and all these kind of things from April 30. That continued. High mobility, heightened use of automobile and transportation up to May 10th. And since the events of incidents of contact, in this case, are reflected several days later, we postulated that this atypical events, we call it, would have an impact on the peak of the epidemic that we had predicted for around in the last week of May. So looking at this, we put together a model, and that included the modification of the Ketra-McKernick model with sanitary emergencies taken into account. We incorporated symptomatic, asymptomatic carriers, since asymptomatic carriers are very, very important. It's a very important factor for any transmission model. We know that there is a large uncertainty in the level of asymptomatic carriers, and this impacts very much any estimation on contact rates and therefore evolution of the epidemic in any model. So our model is this. In the first, in the blue part, you have the typical SEIR model with asymptomatic infectious, recovered, and dead. Then you can imagine here the March 23rd date in which people was enclosed. The non-essential activities were suspended, that is the green box, but some people remain working. Remember, in Mexico, as I think the case is in Brazil, the population with very low income is very large. In Mexico, the people that live from informal economy are estimates that reach up to 40%. So, and these people live in the, work in the streets. They are vendors and workers that have to go out. So the number of people that stayed or was forced to leave confinement measures was very large and due to economic reasons. But in any case, it was a noticeable separation of reduction of the population outside. So what we are modeling the thing that the previous speaker talked about, this kind of behavioral trait in which people get tired of being under lockdown, and then they leave, they abandon the lockdown measures and go and behave as those people outside. And this rate is omega. Omega is the rate at which people stop complying with the restriction measures and start behaving as the population outside. In this case, we assume that the contact rates here, these betas, are higher than this, but we consider, again, here, a behavioral trait. People, is not that you tell them, you don't go out today and tomorrow the contact rate is low. It takes a time to learn. It's a learning process. So we assume that beta K, this red line, is the contact rate of the epidemic before the lockdown measures were installed on March 23rd. Then there is a time, theta 1, in which the population, in average, the time it takes to the population to learn how to reduce the contact rate. And after that time, you have a target contact rate, which is lower. And we assume that this happened both to the people outside confinement and inside confinement, but in different levels. Obviously, inside confinement, the reduction was larger than outside. So with this, we use Bayesian estimates to Bayesian inference to estimate the different parameters. These are the recovery rates for asymptomatics, symptomatics. These are the actual effective contact rates. This is the reproduction number we estimated for our epidemic. And this is the rate, the mortality rate that we estimated from the case fatality ratio, from the number of reported cases. So this is not the true case fatality rate. This is the case fatality rate related to the cases that are reported. This is very important. It doesn't play a big role in what I'm going to tell you, but it's important to point out that this is that kind of case fatality rate. And then we proceeded with our estimates, and we found very interesting things. It is, at least to us, this paper is published, but we think it was exciting. As you can see, this is incidence, and this is how the incidence, maximum incidence, changes as you change the proportion of people under confinement. This is Q. And so you can see that this kind of a minimum here. This is an optimum value. And this is due to the following. We have a trade-off between lockdown, which is Q, and omega, which is the people that leave confinement because of different reasons. So there is a balance here where you enclose few people, the omega rate is very small because it's relative to the people enclosed. But as you increase the proportion of people under confinement, the rate at which people live is increased because the relative number of people that live is higher. And there is a point in which these two things balance, and this gives you the minimum that is around 0.6, 0.7. This also allows you, this estimate of the incidence, although it's given in numbers, in proportions, is not as accurate at the dates in which the maximum can occur. And as you can see here, you have the months and dates of the months, and this is Q. And the minimum essentially occurs by the end of May, beginning of June. And this resulted to be correct in that sense. So these are only examples of the different epidemic curves that you can obtain when you change the number of people under lockdown for the same omega rate of not compliance with mitigation measures. My time is getting to the end, but let me show you only that this property of the minimum is general for several values of the confinement proportion. But I'm going to show you by the end to finish my talk, the effect of the atypical events. We use this model, and then we say, what if omega, it's a proxy for these atypical events from Children's Day and Mother's Day. And we increase omega here, increase mobility only during these dates. What is the impact of this increased mobility on the incidence at the maximum peak, at the maximum incidence? And this is a strategic model. We don't claim, we don't have exact estimates of omega, for example. We are only using approximate data to explore the possibility that arises from these atypical increased mobility events. And this is the aim of the model. It's only strategic, and this was communicated to Mexico City government and to university authorities. And you can see the effect. If the effect is, the peak was around May 20th, May 30th, and this is the dates of the 10th of May. And you can see that if you increase omega, depending on how large is the increase, you can have an epidemic curve that is a little bit broader, or you can have definitively a larger peak and later peak. This is the cumulative number of cases, as you can see. The blue one is the baseline, but even in the case of low mobility event on May 10th, the cumulative number of cases is still increased, and for larger mobility is even worse. And this is the plateau. This is what we are seeing, and we think it is really, at least the beginning of the plateau up to June 1st is related to the atypical mobility that we suffer from the first day of May. As you can see, it is clear there that a plateau arises just because of this. After June 1st, you have a problem because you lifted the conditions. Actually, Mexico City, using this information and others that they have recollecting from hospitals and other data, they decided not to open the city on June 1st, but delayed 15 days. So Mexico City lifted to the orange color of the light only after June 15. So this is just a closer up of our prediction, well, our projection, our scenario, and this is data that we have, in which you have obviously the plateau there. So we don't claim, we are not fitting the model. We are not giving parameter estimates. We are only saying, beware of these atypical events. We have to consider them if you want a Kerr-McClendrick model to give you right scenarios on the development of the epidemic. So that's, I think my time is up. So it's just, in the world, we are using these kind of models all over the place, but transmission models are very, very sensitive to many different hypotheses on contact rates, initial times of the initiation of the epidemic, and other parameters that are asymptomatic, for example, the proportion asymptomatic. We have to be careful. And strategic models are a way of looking at the big picture without the problems that you have when you want to precisely estimate parameters. So it's a kind of trade-off between these two needs. And that's all for now. Thank you very much for your attention.
Thank you, Professor Velasco. Well, Brazil, the Children's Day is on October, so we should keep an eye out for that. Yeah. So please unmute your microphone so we can give him a live round of applause and appreciation for his talk.
Thank you. Thank you.
And our last speaker will be Dr. Pratik Sinha. So Dr. Pratik is an assistant professor at Washington University in St. Louis. He'll be moving from UCSF San Francisco soon to his new university. He has been working on biological phenotypes of acute respiratory disease syndrome and device models that will allow the implementation of phenotypes in real-time scenarios. During this pandemic, his work has contributed to emphasize the risk of premature phenotyping of COVID. He has also analyzed the pros and cons of different forms of digital contact tracing. And so here he will share with us his ideas about individuality and privacy costs of digital contact tracing. Thank you for sharing your point of view and thank you for coming. You have the screen.
It's a pleasure. Thank you very much. First of all, before I get into introductions and slides, I want to personally thank the people of Brazil for lending two of the most outstanding soccer players in Roberto Firmino and Fabinho, who has helped my team, Liverpool, win the English Premier League. So I'm going to start by first kind of reintroducing myself, and then I'm going to talk about what I intend to discuss with you. Firstly, I'd like to congratulate all the speakers who have presented so much great work that's going on surrounding this, and really reframing for me at least what some of the challenges are of contact tracing in this global pandemic, and how people have been innovating. So the title of my talk today is Contact Tracing, Can Big Tech Save the Life? Can save the day? And the more important question from my perspective at least is, at what cost? I'm a specialist in intensive care medicine and emergency medicine, and I'm a physician scientist with my interests mostly in sort of translational biology and data science. But really the question that brought me into this was, how does this affect the way that we deliver care to our patients in terms of being able to provide an equitable and a just healthcare system that protects people's privacy, but also importantly, from a scientific perspective, what are the right questions being asked? i.e., how do we know whether these systems are efficacious and whether they work or not? We know that SARS-CoV-2, the virus that causes COVID-19, is actually a very deadly virus. These are the charts of the total number of cases that are rising, that are being reported. And as you can see in the orange line in the country of my adopted country, the US, that these cases are really rising quite fast. And the same is true of Brazil too, where the number of cases are on the rise and increasing. And this chart looks at the number of deaths per 100,000 cases. And as you can see here, again, that the case fatality rate of this virus seems quite high. And my country of origin, that is the United Kingdom, you can see that the deaths per 100,000 cases is actually quite high. And followed not so behind is the United States of America. And for the local audience, you can see Brazil too is trying to play catch up with all of these two other countries. So the other thing about SARS-CoV-2 is that not only is it quite deadly, it is also quite a clever virus. It's quite a clever enemy that we have. Now, this is the basic reproduction number of the virus, the R0. And as you can see, it sits over here. Sorry, let me just bring my pointer up. it sits here somewhere in the middle. It's got a higher reproduction number than H1N1, but also the case fatality rate is higher than flu, but it's significantly lower than some of the other viruses that we know that cause problems. And here's the thing, it's even though its reproduction number is lower than the original SARS virus, the affinity of the virus and its spike protein to the cells that it enters, the receptors of the cells that it enters, is essentially higher, which means that once it gets stuck, it has a greater chance of getting into the cell. And there are a number of things about SARS-CoV-2, which is sort of quite annoying from a public health standpoint, in that it's not infective enough that it causes rampant infection and herd immunity. However, it's not uninfective enough that we can really have a fairly unrobust contact tracing system to try and get on top of it. And part of the reason is that the burden of asymptomatic carriers in this particular virus is quite high. These are groups of patients or people who actually have SARS-CoV-2 but don't have the disease and aren't symptomatic. And it's these people really that are important, because we need to catch them and test them before they go about spreading their disease. So it's to put this another way, just testing people who are symptomatic and just tracing people who are symptomatic is an incredibly ineffective strategy. And this is probably borne true as to why in so many countries this pandemic has been so bad. So really, let's have a look at what the intervention we have thought of. And by the way, this intervention has been very effective. And this is about social distancing and the shelter-in-place orders that have been put in place. On the x-axis here, what you see is the distance that individuals have. And on the y-axis is the absolute risk of infection. And as you can see, these dotted lines represent higher risk of infection compared to the red lines, which are intermediate, and green with low risk. Across all groups, be it intermediate or low risk, you can see that there is an absolute risk reduction, which is kind of exponential, which decays exponential as you increase the distance from 0 to 1 meter to 2 meters, suggesting that actually distancing is an effective method. However, there is a fallout of this problem, and that is that it has caused the economy worldwide to capitulate and collapse. And specifically, unemployment is on the rise. And as you can see here in Brazil, there has been 8 million excess jobless unemployed people as a consequence of COVID-19. And the same is true in the US and the UK. So where we're at the moment in most countries, I hazard to add that it's not in all countries, but in most countries where we are at the moment, is that we're currently somewhere around here, where we have managed to flatten the curve of this spike. Some countries have done it much better than the others. And now people are thinking about relaxing some of this social distancing measure and trying to reopen the economy. The risk, of course, is that if we reopen too rapidly, that we are probably going to get a second spike in the number of cases. And many states in the US and some countries around the world are actually already beginning to see that. So the question that we have to ask is, how do we safely open the economy? And many of my colleagues who are on this call have very eloquently described what some of the potential methods are of trying to open the economy safely. And it seems to me that the consensus is growing towards contact tracing as being the way forward. The idea is that if you test positive for SARS-CoV-2 or you have COVID-19, a contact tracer will get in touch with you, ask who the people you are that you have got in touch with, who you've been in contact with recently. They will then anonymously contact these people. These people will get tested, and then the health department will contact those people who test positive, ask them to isolate, and everything will end happily. However, even a closer inspection of this will see that actually things aren't quite as straightforward as that. Here's the first problem. Steps 1 and step 4 both involve testing. And it is here actually that the infrastructure in most countries seems to be lagging what is actually required and for the purpose of this particular strategy. Not only do we need to test everybody, but we also need to provide the results of the test rapidly. I can tell you firsthand that in the US and actually in the UK, this infrastructure does not currently exist. People are waiting sometimes days before they get the results of their test. And in some cases, particularly in the rural parts of these countries, the tests aren't actually available. So here we already have a failing system. And the reason why I'm pointing this out is because this isn't the only other complication. The second problem is we need an army of trained and skilled contact tracers. And this too is lacking. Here is a map of the US. And what you see here is how many of these states that actually currently have the contact tracers that might be needed that matches the amount of caseload in this. And this is slightly out of date because as we know, recently there has been multiple spikes in multiple states. So what you have here in the dark green are the states where they have sufficient contact tracers, or it's estimated they have sufficient contact tracers. And mostly these are either very sparsely populated or geographically small state areas. So, and the orange are the orange states that you see are the ones that don't have sufficient contact tracers. And you can see that this dominates most of the American map. The point I'm trying to make here is that even though these digital solutions to contact tracing are an attractive proposition, in no way is this the absolute intervention here. This is just a very small part of a much larger and bigger problem. And actually, contact tracing in its most sort of rudimentary form, which is to be done manually through multiple repeated rapid testing, is actually the way forward. But the question is, can big tech come to the rescue, and if so, at what cost? And this is a paper that I published, and I'd like to acknowledge my co-author here, who's a brilliant entrepreneur and a digital security guy who works for a firm based in San Francisco, which is called Digital Shadows. And him and I basically got together and asked the question: how can big tech help? And what are the security and privacy risks associated with this? And from my personal perspective, what potential harm could this cause to our patients? So here's a simulated study done at Oxford University, which looked at how app usage and how these digital contact tracing apps can actually be effective in terms of reducing the new cases. And as you can see here from the purple line, that no app uptake would cause a much higher case rise compared to if the uptake is about 14%, compared to 30%, compared to 40%, and very low case numbers if approximately 60% of the cases, 60% of the population take up these cases. I will reiterate that this is just an issue of, this is just a simulated study, but also try and keep this figure in mind when I talk about some of the issues of how contact tracing apps might be taken up later. So it makes intuitive sense that using the help of big tech companies, i.e. Apple and Google, and my colleagues have discussed the platform previously, that largely now most contact tracing apps are using the Apple and Google platform. Why could this potentially be an elegant solution? Well, here are the answers. Penetration. It is estimated that somewhere between 96 to 98% of smartphone users currently use either Apple or Google as their operating system. So in theory, we have huge population penetration, and something we've never had before as a species who have tried to control disease. There is the issue of speed. Now, rather than manually seek out people individually and see who the contacts were, where they live, this will give you an automated solution very, very rapidly. Then there is the question, of course, of privacy. In theory, because and I will explain this a little bit more, because the data may be stored on an individual's device, in theory, it means that their privacy may be more protected than having a centralized system. And I'll talk a little bit more about that later. And of course, there is accuracy. Asking individuals to try and recollect who they were in contact with, but more importantly, for what period of time and where. Not all contacts are the same, of course, as one of my colleagues previously talked about, that spending 15 minutes indoor, sat right in front of each other, shouting and arguing, because it's more aerosol generating, has a much greater impact of infectivity than, say, if you're out keeping a distance at 6 meters and you only met for 5 minutes. Now, whilst it might be difficult for individuals to recollect, and we know that human recollection is actually quite poor, and many, many lawyers have got their clients off as a consequence of showing the fallibility of human memory, the accuracy that's provided of the encounter is quite important. And it's also probably quite important and slightly alarming to know that the data are already being collected. And actually, it's not so much of a stretch for these companies. They're already building on these platforms. They're already collecting data at this level. It's just a question for them to organize it in a way that could potentially benefit society. So broadly speaking, the proposed Apple and Google format is that, or most apps actually work on the fundamental principle that your phone, be it person A here who has your phone, they meet person B, and what you do is you fire out Bluetooth-based key codes and signals, or what they're called digital chirps, that are exchanged. These are anonymous passwords that are generated by one phone, and all the nearby phones collect this Bluetooth signal. And they collect this Bluetooth signal and store it locally into the device. And this information is stored until such point that a person is diagnosed as having the infection. And what happens is then they can trigger that they have got an infection, and then this data can be shared. Now, there are two potential routes that you can go from here, where the way that the app disseminates this information. This can either be centralized, where the data is sent and then stored in a local repository, which is essentially been set up by the government or the company that is making the app, versus a decentralized system where the phone provides its own anonymized identity, and it's only this data that is then shared with the government. The differences are that the computer server, which collects and stores all of this data, does the task of matching and the risk analysis, and then resends the information out to either the contacts or the individuals concerned. However, in a decentralized system, it is the phone that has the database and does the contact matching. And so what you're doing is effectively you've got a centralized system where all the data is stored, and it may or may not be anonymized, versus a system that is essentially doing most of the analytics anonymized at a device level. And this table is again from the manuscript that we have published in one of the eClinical Medicine, which is a subsidiary of the Lancet Respiratory. Already this has only just come out 10 days ago, and such has been the rapidity and the evolution of this field that this is already out of date. Broadly speaking, these apps come in lots of different flavors, but broadly speaking, they're either these self-reporting apps, which are actually highly trusted because they're mostly developed by universities and researchers. But unfortunately, I think their utility is going to be limited to the research arena. And I don't think this is fit for purpose for population level and epidemiological level interrogation. So then you have those apps that are custom built and closed source, i.e. the source code for the app development is not declared. And this is important, at least from my perspective, because a lack of published and scrutinized codes increases the risk of security flaws. There may be hidden surveillance, which we're unaware of, and the apps that are on people's computer may be collecting data that is essentially not been consented to. And informed consent is a very important part of autonomy, and it was one of the important tenets of medical ethics of how we deal with our patients. So truly, if you have a closed source app, are the people who are agreeing to sign up to this consenting to what is being declared, or is the app collecting information that is not essentially being consented to, or for that matter, necessary for the task at hand? Several countries, including Norway, Russia, Vietnam, China, and the UK, have been using these closed source type, closed sourced apps. And since then, both the Norway and the UK have ditched their closed source app and are moving to a more open source and decentralized system. The next app source I'll talk about is PEP-PT, which is being used by a lot of European countries. This is essentially an open standard, but not quite open source app, but it's using a centralized platform. And the problem with a centralized platform is that the data that's being selected and kept in a centralized database is very much at risk of attacks and data breaches. And we all know that several government agencies have a pretty decent track record of seemingly losing quite important data to breaches. So there is that problem. And also the PEP-PT platform does not use the Apple-Google-based API. The problem with that is that if you're not using Apple and Google's based API, you risk incompatibility with the operating system, which means that it has problems with battery drainage and efficiency of the app. And this has been problematic not only with PEP-PT, and FYI, since this was published, Italy too is now considering leaving the PEP-PT project for these reasons. But also the Open Trace app, which is the app of choice that's been used by Singapore, their Trace Together app, and also been taken up by Australia, which is an open source app, but not using the Google API. These apps are having problems with battery life and other efficiency issues. And finally, we're going to the Apple Google API. It's worth emphasizing here that Apple Google themselves are not developing the app. This is just the platform which these apps are using. And the most probably important project is the DP3T, which most recently Germany has joined. Germany was previously part of the PEP-PT. And this uses the Apple Google platform, and it uses the native operating system and its functionalities, and the information about the contacts is essentially saved on the patient's on the individual's device. And from a privacy standpoint, certainly, whilst this may not quite be good enough, and there are some worrying issues about how invasive these big tech companies already are in terms of our digital footprint. However, what this offers, in my opinion at least, is open source apps where you can scrutinize what the apps propose to collect, and the data is saved on the patient on an individual's device is much preferable to these closed source decentralized platforms. And this just shows you on a scale of this being the most centralized, the countries up here being the most centralized versus down here, which are decentralized. And this may in some ways reflect how different the economies are, how different the democracies and economies are in these countries in terms of what might be tolerant. For example, in countries like the US and UK, where civil liberties is an important thing, I think a decentralized platform is more likely to be taken up. And the problem here is about app uptake. I showed you in that chart previously that the greater the uptake, the more likely the efficacy of this is. And I would, again, once more, probably emphasize this, that these are all simulated studies. And it's very important when these apps are being introduced that we test this in the scientific settings, so that we can look at the sensitivity and specificity of this essential diagnostic intervention. And I'm yet to see any convincing data on that. So the app uptake is of huge importance. However, the uptake has so far been variable. In Singapore, the entire population uptake had been 20%, but because of the issue of this not being on the Apple and Google platform, the battery life has been a problem. Essentially, when this initially came out, you had to have the app running at all times, which meant that it was draining people's battery. In Iceland, which is probably the best example of where the uptake has been very good, 40% of the population have taken up the app, and people cite this as an example of success, but it's worth thinking that actually there are only about 350,000 people in Iceland. Germany, with its newest app, which is a decentralized Apple and Google-based app, the uptake has been close to 12 million people. Turkey and Qatar have gone down an interesting route where they've made the app mandatory, and it'll be interesting to see how efficacious it is. But generally and overall, the uptake has been fairly poor. And it's important to note that there is generally a big mistrust amongst the public about taking, and this is data from the US about taking up the app. And as you can see, this is a survey of about 2,000 American citizens, American residents, and this only came out yesterday in preprint. And at the top here, temperature check and traditional contact tracing are the most trustworthy and have the highest level of support. And smartphone contact tracing is down here alongside thermal cameras, CCTV, and electronic device monitoring, so the more invasive form of contact tracing. And why might that be? Well, the biggest concern people have is concerning about privacy. And I think this is an important concern that people have. There is also a case of security and the fact that apps don't work. And to be honest, it's not just the American people that have this concern, but I too am concerned about all of these things. So what are the things and what are the conditions that may improve people's uptake of these apps? Well, look, here we have apps that are sort of developed by government organizations such as CDC, state government, researchers, people seem to have a greater likelihood of downloading the app if they are. Whilst there is a trend, it doesn't reach statistical significance, 0 in this case being the Apple and Google developed the app, which actually doesn't happen. Also important to note that decentralized app, and this goes back to the issue of security. So if your app is decentralized, then this increases the likelihood of you being able to take up the app. And also the fact that these apps need to be time bound, in that if you basically give people information that this is time limited, it's more likely that the app will be taken up. And it's interesting to note that the percentage of users that need to take it up does not make a big difference in whether or not the app is being taken up. So the important issues are that it's secure, and it is that there is consensus, and that privacy is not being unduly invaded, and also that it's interesting that apps that propose using location tracking increases if you have no location tracking, then it increases the likelihood of people taking the uptaking the app. Although it seems as though the efficacy of the app may be better if there is location tracking and not just Bluetooth. So these are the conditions that we have concluded would help improve uptake of the app. In terms of the development phase, the source code has to be open access. We need to know exactly what it is that the app is collecting, because we think transparency will increase the uptake of these apps. The data handling, how it's collected, whether the consent that we take of our patients, and we can consider them within the remit of patient ethics, is that the consent is informed and the data that is being collected is required only, and that the storage is decentralized. And it's important that when we're thinking about scaling this, that we collaborate, but this is not just in an intra-country level, but also at an inter-country level, because it'll allow us to look at the conditions where these work, whether it's in urban areas versus rural areas and suburban areas. It's important that we use this information across boundaries, because this virus knows no boundaries. It seems to me that these sort of national boundaries that we have created are in some ways unhelpful within these conditions. And it will also make the testing of this and the app development more cost effective. In terms of legal issues, the laws pertaining to civil rights need to be time bound. The data needs to be protected for the intended purpose only. And we all know that emergency measures which come in, governments are terrible at repealing that once these crises are over. We need to ensure that when this is over, that these apps and the data and the laws that are passed in order to study and track people are repealed as soon as we feel confident that this is over. And they need to meet regulatory compliance. We need to make sure that these are actually effective, the sensitivity, specificity is effective, but actually also that the technology is effective. What is the false positive and false negative rates? We don't know any of this yet. And this needs to be proven in order to increase the transparency and reassurance, and actually have a coherent, unanimous consensus that what we have here, what we're offering people, actually is safe, it's secure, and it's an effective intervention. And we think uptake is highly contingent on transparency, about public information, and health campaigns. So to summarize, there is a need for transparency and privacy preservation when we develop these apps. There needs to be equity and justice. And this is important because in South Korea, for example, once the contact tracing begins, you can even extract by law the immigration status of the population. And if this were to happen in the US or in the UK, undocumented immigrants who are in some ways the backbone of the economy are less likely to report the conditions. They're more likely to go in when they're sick, because if they take time off, people will say these people are infected. And what happens is that there is an inequity of healthcare delivery. That not only do these people not seek healthcare, but also they're penalized and scrutinized, which will increase spread and also cause undue distress to these people. There is also needs to be thoughtful consideration about how we deal with people who have been detected through contact tracing that they have an infection. What support system do we have for them, their family, their economic support in terms of the time off they will have to take for isolating? And I will reiterate here that there needs to be public health and government measure, and we all need to participate equally in this as citizens, that digital contact tracing on its own is only part of the solution. And in some cases, I agree with some of my colleagues who earlier said that it might not even be that effective. So with that, I thank you. You can follow me on prog.talk. And I'd like to thank Alistair Patterson, my colleague, my esteemed colleague and my friend who has helped me think about these issues more thoughtfully. And with that, I end my presentation. Thank you very much.
Thank you, Professor Sinha. Please unblock your mics to give him a nice round of applause for such a nice talk.
Thank you.
So now I'll ask this is our last talk. So I'll ask the speakers to unblock their cameras so we can have a little bit of a question and answer session. As you can see, the topics are all very well related, and we've been receiving some very interesting questions, and I'll direct them to you now. But I know that Professor Leonie has to be somewhere else soon. So if you don't mind, I'll tell, even though it's out of order, I'll talk about her question first, because it's very specific to her talk, and then I'll direct the more general questions. So Professor Leonie, this is from Dr. Felix Hector Rigoli, a researcher and lecturer at Núcleo de Bioética, Diplomacia em Saúde in Fiocruz. And his question was, why did you decide to base the flags on the availability of ICU beds and not stressing the high rate of testing indicators as positivity rate or test per million as criteria when these are recommended?
We have started using tests, but we have a low availability of tests in states. So using tests was not saying much to us. And we also started using the RT-PCR, PCR, I don't know how to say that in English, but we're using only those testings, those who are hospitalized. Most of the indicators, not all indicators, but most of the indicators use hospitalized and PCR, because when we were using all the tests, we have created a bad incentive for mayors not to test. So those who were testing and identifying more, they would go to higher risk, and they started testing just because we have created the model using that. So as our purpose is not to let the system fail and to provide assistance to everyone. So we have focused on hospitalization and on ICT beds, especially for the purpose of this model of the flags. Anyways, we also look at other fronts. We are not looking only at the flags. They are very important because the flags, they set how society behavior, human behavior is going to change according to, of course, different rules on different settings. So we have, for instance, on red flag, public transportation dropped to half. We have the closure of retails. We have industries slowing down. We have all sorts of activities, not only economic activities, but all sorts. Schools are closed anyway. Since March, we have not opened school. We are discussing as many parts of the world or when and how, but it's not in our radar right now, returning to classes, especially because some areas are getting into higher risk. So that's why first we didn't want to create bad incentives. We have low availability of tests. I think this is very important to say because as we're working in governments, it's very difficult to buy. We have tried to buy, and some of the procurement, they were empty, as you say here in our, so no one have presented to selling tests. Because of that, we have decided to focus on hospitalizations, but we also look at the general numbers, not only daily because of the results of the labs, but also looking at using the random prevalence research that we conduct with a federal university here in Rio Grande do Sul to follow how the virus is spreading. On contact tracing, we are now starting another project with Todos pela Educação, Todos pela Saúde, All for Health. It's a NGO here in Brazil on trying to get into people who have all the symptoms but are have not been tested. So we're trying to build a model so that we can reach 3,000 tests every day. And one of our problems is that it's the lab availability, not only the test, because we are managing to, donors are trying to put it together, but availability of instruments and tests. But is it? Thank you so much. I'm so sorry I have to go, but have now another.
Thank you for joining us.
Thank you. Bye-bye.
Bye-bye. So for the remaining speakers, there are some very general questions that I think will interest all of you. So I think it'd be probably more exciting and also interesting for yourselves if just feel free to answer the question if you feel you want to. So this was not directed to anybody specifically. This is from a science journalist with a global newspaper here in Brazil called Rafael Garcia. And he states that the WHO is pushing for strong contact tracing efforts everywhere to help slow down COVID-19. And like you all exposed here, it only pays off if you implement it before this intense community spread. So his first question is, and I open this to any of you who want to answer, but I think that probably Elden or Pratik will be more familiar with his team, is should we go about tracing the contacts for every confirmed case in Brazil, as we have over 1 million cases? Does contact tracing pay off, even if a country doesn't try to cover all the cases that are reported?
Well, I think that in terms of technological possibilities, yes, we could do that. Pratik show a bunch of apps that can be used in different levels and for different applications. But I do think that it's almost too late because we would have this huge bottleneck of testing a lot of people that we are not even doing this right now. Enforcing lockdown that people are just not following, although we receive messages from the government, people in the day-by-day life are not following. So I personally do not think this could directly help, unless like really there is a social contract that people really use it, really test, but I think that this myriads of apps are actually confusing more people. Like people get tired of installing a new app, so that's why I brought the idea, and I wish Pratik tell me, because he did the survey of apps, if there are like apps that tells you like before you go to a place if there is already a lot of people there, like something in that sense, like so because now that the epidemics are installed, can we prevent us to get into crowded places, like by using these kind of technologies instead of trying to go back and trace when it's all over already, the places.
Yeah, I agree with Helder that I think for where we are right now in the pandemic, it's probably too late for that strategy. I think what the person who asked the question is, I think what they're alluding to is at what level of population screening do we need to intervene at, right? Let's face it, we don't have enough tests to do that level of population screening at the moment. But what contact tracing and potentially digital contact tracing might do is allow us to focus and have more efficiently identify subsets of the population that need testing. In response to Helder's answer about what apps might warn you which public crowded places to avoid, we don't need apps for that at the moment. From a public health standpoint, avoid them all. Don't be in crowded places, right? We need to just re-emphasize that. Indoors, crowded places with the population prevalence of SARS-CoV-2, the chances of you being in a high-risk situation are way higher than not. Okay, we're not there in this pandemic yet. In Brazil, in the US, we are just not there. We need to go back, socially distance ourselves, and then rethink about how these technological interventions can help direct who the people are that we need to test more efficiently. And I think that's where technology can help. Right now, the interventions that are important from a public health standpoint are very different.
Thank you. This is actually one question that I have, so I'm going to use my privileges to ask this. Is it possible to use the data from mobility data, for example, that Elden collected, to input into mathematical models like Professor Velasco has to predict how the curve is going to be? So instead of using it to prevent the disease, but rather to monitor parameters, because Dr. Velasco said that he's using theoretical values, could you input that as true values to add into a mathematical model to make it more precise?
Yeah, I think that's the next step, right? Once you detect that there is a trend in the population, you want to be more precise. And for that, you could incorporate these kind of models. There are several models. I just was in a conference in Chile, video conference in Chile, and they're using mobility data to incorporate in the models very similar to the ones more complex, but the same type, for mobility, and to study the different counties that they have in Santiago de Chile in order to evaluate better the mitigation and lockdown, sequential lockdowns that they are implementing for controlling the disease. So that's the next steps, as that's being used. I understand also that even for the effective reproductive number, there are algorithms that already incorporate mobility data into that to better appreciate the changes in transmission. So that's been done, and that has to be probably incorporated into more models, because as Pratik was saying, now in Mexico too, the priorities don't go to crowded places. But as the evolution of the disease evolves, and we have to go out, we have to reactivate the economy, this kind of data and this kind of inputs on the models will be very, very, very useful, and definitively they have been incorporated into them.
Yeah, thank you. That's such an elegant answer, Professor Velasco. And I think, it's very important to emphasize that we are using some of that data too. And the overwhelming signal that we're getting is that people who are in more economically deprived counties are the ones that are suffering here. And that's why infection spread is greater. So for example, when the lockdown measures were lifted, the increase in mobility data in affluent counties went up by 150%. But in counties that were economically deprived, that change was only about 10%. So these people are already having to serve the economy because they're essential low-paid workers. They live more people in one houses. Again, we can tell that by location data. So, that's where we can be more efficient. But who are the people who are most vulnerable and who are most likely to spread the disease? And how can we provide better conditions, economic conditions, and better healthcare interventions for these people? And really my mandate through all of this is we don't just need to think about people who have these apps and who are economically well off, but there needs to be a just healthcare system that we provide for people.
Thank you, Pratik. The next question is to Dr. Ekong. So your tracing system doesn't include the asymptomatic population, so it's mostly a report of symptoms. So how do you include that, the fact that the symptomatic patients also can be carriers? How do you correct for that in your prediction?
Yeah, thank you very much. Interestingly, presently, 70% of our cases are actually asymptomatic. And then there's evidence that's showing that even within a household, you have the index case infecting, say, a couple of people in the household, and some of them would still be asymptomatic. So basically, the model that we're using is that once you identify a hotspot, you're going to see different kinds of cases, symptomatic and asymptomatic cases. So what we're looking at is looking at a hotspot that will, that will drive your testing priority. So if you identify a hotspot and you move in to test that hotspot, you'll find out that in the hotspot there are asymptomatic and symptomatic cases. And then by the time the result comes out, you're able to identify, both the asymptomatic cases. So that's just the strategy.
Thank you, Dr. Ekong. So our time is up. There's a time limit to this webinar, unfortunately, but I hope this will generate further collaboration, discussion among yourselves, and also some of the questions that have gone unanswered from the public, we'll direct to them by email, and then you can continue the discussion outside this forum. So again, I'd like to thank everybody for this very productive and informative webinar. And now I'll ask everybody to unblock their cameras so we can have a group photo as a memento for the moment. The media staff would take a picture of everybody. And again, thank everybody for joining us and sharing your time and ideas. And hopefully those will come out productive discussions in the future. So are we all set? The picture? Somebody, okay. I think everybody's almost in. All right, media guys, are we set? Help me out here. What I'm supposed to do? I think my part's done.
Yeah, that's okay.
It's okay.
I took the picture.
I think we have 2 people who are still off. Is that okay?
Yeah, let me see. It's Vera from events team.
We have a compliance problem right here.
That's okay.
Oh,
That's
there
okay
you go.
now. Perfect.
Okay. Well,
Okay.
thank you very much, and thank you for joining us.
Thank you so much, guys.
Thank you.
Well,
Bye-bye.
Thank you.
Thank you.
Nice meeting you.
Thank you. Stay
Nice to meet
safe.
you.
Thank you all.
Stay safe.
Bye.